show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today on the show, we have Stephen Parodi. He is an infectious disease physician and healthcare executive. He wrote the Kevin MD article, "The Public Health Emergency Brought Healthcare into the 21st Century." Let's keep moving forward. Stephen, welcome to the show.
Kevin, it's great to be with you.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Oh, sure. Yeah. So, I'm an infectious disease doc and have always been interested in epidemiology and, improving the clinical care of patients. And a lot of my practice has been moving care out of the hospital. So, early on, home IV antibiotic therapy. And when I moved into some more operational roles in hospitals, how could we move more care out of the hospital, like surgical care? And back in 2015, we actually introduced a program within Kaiser Permanente called the Enhanced Recovery After Surgery program, which ended up literally taking total joint surgeries and moving them the outpatient setting. And then lo and behold, we said, can we do that for medicine patients? And so back in 2018-19, we started talking about how can we actually provide this care and do this safely. And so we did actually patient focus groups, clinician focus groups, and started putting together what the logistics would be to provide hospital level care in the home. And then the pandemic hit, and that sort of supercharged things where we were able to get a number of regulatory waivers in place and then to actually put together the teams, both the remote teams and then the in-home teams, connect them together with an IT system that allowed us to do this.
So when you talk about hospital level care at home, what kind of conditions are we typically talking about?
Yeah, so, since we've launched the program, we've had about 1,600 patients enrolled in the program, both in Oregon and in Northern California. The vast majority of them, I'd say probably about 70% of them, are some kind of infection-related issue. Although I want to just point out, most of them were not COVID. So these are, more bread and butter type infections, pneumonia, cellulitis, urinary tract infections, that type of thing. But then we've actually branched out and are taking care of a lot of conditions, heart failure, small bowel obstruction, complicated multi-system level sort of sepsis, that type of thing. So it's a broad-based program. These people have to, at the very least, meet interqual criteria, but moving beyond that, these are people that I think would, most clinicians would say typically are med-surg level patients.
So give us a case study or an example. Let's say an elderly patient with COPD comes to the emergency department and gets diagnosed with pneumonia that requires hospitalization. If you were to implement this program, hospital level care at home, how would that look like?
Yeah, so the way it works is, I'll just sort of walk you through the patient journey. So patient shows up to the emergency department. We've already done a lot of pre-work to make sure that the ED physicians and the hospitalist physicians are comfortable with the concepts of the program. They'll do both a medical assessment, clinical stability assessment, and then a social screen assessment to make sure that the home is safe. And then they'll offer the patient the option of potentially going home. We also offer the option of being admitted to a regular brick and mortar hospital. If the patient says yes, then we actually have the virtual hospitalist actually come into the room and do a virtual examination. They write the orders just like you would in a regular hospital. They're admitted. Then we transport the patient to the home. There, they're met with essentially either a physician assistant or community paramedic who does the, again, screen of the home itself. They actually set up the Wi-Fi. They set up the IT system that the patient's going to need to communicate with the remote command center that has a typical team: hospitalist, nurse, social worker, program coordinator. And then the patient's able to actually have direct remote access. It's pretty cool. It's got either like an iPad where you hit a button and it gets you directly to the command center. And if they can't handle video technology, we give them essentially what looks like a bat phone. Pick up the phone, goes directly to the command center. And then it's two-way communication. So then we can actually radio in. And then we have remote patient monitoring so we can get vital signs. The patient can call for help at any time, even using like a watch-like device. And then they're usually typically in the program in acute setting for about 3 to 4 days on average. And then we have what's called a recovery phase as well. So basically what would look like post-acute care from a typical hospital. So the same team can actually provide that longitudinal follow-up as well.
So how about things like intravenous medications? How are they administered at home?
Yeah, so, basically what we do is once the orders are written, the medications are delivered typically by the paramedic, and then they will be administered. So we place the IV in the home. If they're going to need long-term IV therapy, we can place PICC lines in the emergency department and have them transferred to the home. And then the IV medications are delivered, however often they need to be delivered. So typically a patient's being seen at least twice a day in person, but if they need, additional IV therapy, we can do that. And I'll just give you another sort of really interesting example. We've figured out workflows for being able to push high levels of IV fluids. And so we've admitted people with rhabdomyolysis and actually have the correct type of IV pumps that can deliver a liter or two of fluid in rapid succession in the home.
All right, let's talk about the Kevin MD article that you wrote. It's titled, "The Public Health Emergency Brought Healthcare into the 21st Century. Let's Keep Moving Forward." Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, so, one of the most important things about the ability to stand up a program like this has been that the traditional rules that allow us to provide care either in the hospital setting or like do home health care, none of them seem to really apply very well to being able to provide this high acuity level care in the home. And so with the start of the public health emergency, we were able to implement a lot of what I just described because there were waivers put in place related to the public health emergency. Some of them related to telehealth, and then some of them related to specifically hospital at home. And there was an actual waiver called the Hospital Without Walls waiver. All of those are tied to the public health emergency. And of course, all of us hope that the public health emergency is going to complete or at least end. And there's a lot of anticipation that by the end of the year, the federal government will say there is no more public health emergency. And so unfortunately with that comes a cliff essentially as it relates to all these waivers. So the reason that I was compelled to write this article is that we now have more than 200 hospitals and in 34 states that are actually operating using this waiver to provide hospital level care in the home. And the only fix here is actually literally an act of Congress. So I thought it was important to get the word out that number one, this is an emerging and important, I think, therapy and extension of the hospital and extension of physician practice that we don't want to see end. And the more voices, the merrier here in terms of pushing this forward.
So tell me about the legislation that's currently being considered to continue this.
Yeah, so there is right now a bipartisan and a bicameral piece of legislation that is called the Hospital Inpatient Services Modernization Act. And essentially, it would extend the waiver protections beyond the public health emergency. It would waive the requirement for the on-site 24/7 nursing that's required in a brick and mortar hospital and continue to allow us to provide those in-person services as long as we're providing 2 in-person visits a day with nurse virtual backup. The other thing that the legislation I think is really important here is that it sponsors or at least pushes CMS to do studies to actually look at the efficacy, the cost effectiveness of the programs, the safety of these programs, and we definitely need more data. I cite in the Kevin MD article about a New England Journal article that has shown promise in terms of these programs. And, of course, there are a number of programs, including the ones that we've been doing, really show that this program is promising from both a safety perspective, length of stay perspective, patient satisfaction perspective. I mean, patients prefer to be at home. Of course,
yeah.
I mean, and I'll just tell you as a clinician, it's so more satisfying to be able to tackle, why is this person getting heart failure? Oh, let's open up the refrigerator and actually see all the salt that they're eating. And I always use this other example here, which is, we're required to do med reconciliation at the time of discharge.
Mm-hmm.
Okay. Let me just tell you, there's no way to do real med rec. Real med rec is when you're looking at the person's kitchen table and you see a bunch of medications that are expired, a bunch of medications that are actually probably old prescriptions they shouldn't be taking anymore, and maybe what their cousin gave them. And that's actual real clinical practice. It's very satisfying because it's, I can remember actually early on when I started my practice and was doing HIV care, and I had a number of patients that for transportation related issues couldn't come in, and I would literally go to their home. And I can tell you the insights that you get are really incredible. So this one patient that we admitted into our program, he was sort of what people would term a frequent flyer. So coming in with repeated lower extremity cellulitis. And actually he got fed up actually being readmitted to the hospital. So he refused to be admitted to the hospital, but was willing to be admitted into this hospital at home program that we had set up. And we got it back there into his home. And it was interesting. The PA actually came up with the idea of connecting with this patient. And he noticed that this patient had a bright red truck in his driveway. And he said, what's the deal with that bright red truck? And the patient was like, well, that's my pride and joy. And I'm not able to drive it because my leg keeps getting infected. And he's like, okay, so your goal of care essentially is to get back into that truck. He's like, yeah. And he said, well, you're going to need to change your diet. You need to, deal with the diabetic management that you've been non-adherent to, and you got to take the antibiotics we're prescribing. And what ended up happening is we redirected the focus. Instead of medicalizing all of it, the entire team focused on the red truck. Patient's way more satisfied. He hasn't been readmitted. And it just gives you, the social insight as well as the medical insights that we couldn't otherwise have.
So I think what you said about medicine reconciliation certainly resonates. I'm an internal medicine primary care doctor, and the only true way to do reconciliation is this: to literally have the patient bring their plastic bags full of medicine bottles and kind of going through exactly what they're taking, or the duplicate medications they're taking, and like you said, what other people are giving them. So, Steve, what happens if this piece of legislation doesn't pass?
Yeah, so it is a real risk to a number of the programs in terms of being able to continue, and certainly I can tell you where I work, Kaiser Permanente is committed to continuing this program, but it'll be done in a patchwork fashion. I mean, that right now, unfortunately, the regulations really limit our ability to extend the program and expand it. So I don't think the programs will completely end, but it will certainly slow down the momentum that we've had. And I can tell you that in terms of being able to enroll patients at scale, which I think is really what we need to do. And by the way, let me just say another reason why I think this is a can't fail type of moment is that our hospitals are still chock full of patients. Right now our EDs are full of patients who have delayed or deferred care. We still have COVID going on, by the way. And so we need this additional hospital capacity. So my answer to you is that this is really something that we can't afford to have fail.
We're talking to Stephen Parodi. He is an infectious disease physician and healthcare executive. He wrote the Kevin MD article, "The Public Health Emergency Brought Healthcare into the 21st Century. Let's keep moving forward." So, Stephen, under ideal conditions, let's say this piece of legislation passes and funding continues, what do you see as the future of hospital level care at home?
So I see actually expansion of this program. And so what I envision here is that, of course, we're working with hospital at home. And what we're finding is greater continuity of care. And I reference this a little bit here. When you discharge a patient from their home hospital setting, they still have ongoing needs. Now, they may need, limited follow-up where they need follow-up with the primary care physician. And we're now finding that we're able to bring in the primary care physician earlier to the process. So there's actually a cleaner handoff, a warm handoff, instead of one where there's a cliff after you leave the brick and mortar hospital. But people have post-acute care needs. So they may need ongoing PT, OT, speech therapy, and we can provide that with a lighter touch than the full hospital team. But we don't have to completely transition off the hospital team. So we may have a physician that rounds, every couple of days or every 3 days, but they've got the PT coming once or twice a day. And again, that prevents readmissions, literally readmissions into either the hospital at home program or into a brick and mortar. So just to give you a sense of that, we've seen basically a 40% reduction in readmissions in terms of 30-day readmissions. I'll give you another example. I mean, why would you admit a person in the home, be able to take care of their acute needs, and then put them in a skilled nursing facility?
Mm-hmm.
You wouldn't do that. So, we're actually dipping our toe into what skilled nursing care might look like in a home. I'll give you one other sort of example that has been piloted, and that's providing cancer care in the home. So one of our partners that we actually exchange with, the Mayo Clinic, has actually done a study, as well as Mass General, looking at and enrolling people that are getting cancer chemotherapy and doing that in their home and providing the post-acute care, like neutropenic fever, for example, in the home. So, I don't think this is just going to be limited to, bread and butter hospital care. I think there are going to be other, just think about the things that we put into an infusion center today. Why couldn't those be done in a home as well?
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
So a couple of things. I think this is such an exciting time. We've been through a difficult period here with the 2.5 years of the pandemic. And no doubt this has been complicated for our patients, complicated for us as clinicians. And yet there's an opportunity here to shape and reshape the way we provide care. And this program is so exciting to me because it is person-centered. It is really getting literally back to the future, getting our, virtual black bags and being able to go into those people's homes, but do it at a greater scale than, say, perhaps the folks that were back in the early 1900s doing this. It just feels very genuine to me, and it's very person-centered. And I got to tell you, the feedback that from our patients has been through the roof. And when you ask them, would you rather be in a brick and mortar hospital if you had to be admitted again? And the universal answer is no. So I think what we're seeing here is a transformation of the way we can provide care and probably the way we should do it.
Stephen, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you, Kevin.